Assalamu alaikum. At the end, you can proceed here, please. Except here. Just proceed. Just get down. So, I didn't teach you before. Inshallah, I'll teach you this lecture for the neuro, and next year I'll teach you more for the pathology in many blocks. Just proceed in the front, please. So we'll go through two lectures for 2 hours. In these 2 hours, we'll go through the CNS neoplastic process. And if you just focus and pay attention, inshallah, I will go home with whatever we need about the CNS tumors. So you just go home and review the lectures. As I said, I didn't teach you before, and inshallah I'll teach you more next year. I hate to be late. I like to be punctual. I like people to be punctual. I don't like people to come late to my lectures at all. So for this year, this is the first and the last lecture which I teach for you. But for next year, inshallah, I will see you more in many pathologic lectures. So kindly be on time on my lectures. Don't be late in my lectures. On my lectures, I need full attention. Close your cell phone. No open cell phone at all. Okay? So, we'll start with the CNS tumors. CNS tumors are really an important, very important topic. It's important topic. CNS tumors, the annual incidence is between 10 to 17 per 100,000 person for intracranial. For intraspinal also it's 1 to 2 for 100,000. It's really important tumors, especially in the childhood, in the young age group of the patient. So it's really important. Remember the young age group of the patient. It comprises almost 10% of all tumors. Apparently we lost the signal. Okay. Remember for the childhood CNS neoplastic process, most of the childhood CNS neoplastic process in the cerebral hemisphere. While for the adult CNS neoplastic process, most of the time in the cerebral hemisphere. So the location is completely different depending on the age of the patient. Young patient in the cerebellum, young adults and old age patient in the cerebral hemisphere. CNS tumors are completely different than other tumors in a way that there is no pre-neoplastic process, there is no in situ, usually no in situ in CNS tumors. Most of the tumors we see without in situ component. You see that in situ component cancers. Just proceed here, please. Proceed, okay? The in situ seen in epithelial neoplastic process, in carcinoma, and all of type of these tumors. In CNS tumors, no in situ component seen. So this is one thing that is really important. The site of the tumors for the CNS tumors is another important factor. There are specific tumors that are seen in specific age. So the age is important in a factor in CNS tumor. We see some type of tumors in some specific age. Site of the tumor is also important because sometimes small tumors, sometimes even well-differentiated tumors can be very dangerous and lethal because of the location. So location is another important factors in CNS tumor. CNS tumors, even the malignant one, extremely rare to see them outside the brain. So most of the time, except in rare cases, we see the CNS tumor going outside the brain. So CNS tumor usually tend to stay on the brain. So this is another factor that is important for the CNS tumors. The clinical manifestation for the CNS tumor is different. It depends on the size of the tumor, the location of the tumor. As I said, sometimes small, well-differentiated, benign-looking tumor behave in a lethal way because of the location. So in many times we see increase in the intracranial pressure, we see headache, we see seizures. So it depends on the size, location of the tumor. So clinical manifestation different from case to case. How we classify CNS tumor? You know, the classification of CNS tumor is very, very difficult and detailed. If you go to the WHO classification, there is no way that you can to understand it in a comprehensive way. So we just go to the simple, direct classification. Depend on the cell type of the neoplastic process. We start with the glial tumors. We have glial cells, we have mesenchymal cells, we have meningeal cells, we have, so we go to the origin of the cells. Like glial cells, you know, we have astrocyte, so we have astrocytoma. We have oligodendrocyte, we have oligodendroglioma, and so on. So we go to the subtype of the cell and originate and create the classification of the tumor type from this type. So gliomas, we have the astrocytoma, oligodendroglioma, ependymoma, and so on. For the neuronal cell origin, we have the ganglioglioma, gangliocytoma, central neurocytoma. So right away we go to the cell type and originate the definition of the tumor. Embryonal tumors, very important tumors. We have medulloblastoma, atypical rhabdoid, teratoid tumors, and others. Meningeal tumor, we have the meningioma, mesenchymal tumor. You know, mesenchymal tumor, wherever we have mesenchymal cells, we can have mesenchymal tumors. We can have sarcoma, we have whatever type of mesenchymal cells in the brain. We have meningioblastoma, and so on. And so on. So we depend on the type of the cell origin to go to classify it in a very simple, classic, direct way. The more detailed WHO classification for these tumors actually is too much. It's unneeded at your level. You don't need to go through these WHO classification. We just go to the simple, direct classification for the CNS tumors. So this is the astrocytoma classification depend on the WHO. It's so detailed, and at this stage of your knowledge it's completely unneeded now. So we go to the simple classification and leave it there. Diagnosis, you know, we start with the clinical examination, physical examination, clinical findings, radiologic findings, imaging, CT scan, MRI, and so on. So we go through the multiple parameters for the diagnosis of the CNS. There are terms that we use in the histology, in the pathology. I said close your cell phone, please. Close your cell phone. Did you hear me say close your cell phone at the beginning, or you came late? You came late? Okay. Close your cell phone. Okay? So there are terminologies that we use in the histopathology actually, It's not related or it's not restricted to the CNS. It can be seen anywhere else. Like we use the term of warts, something like onions, onion skinning or onion-like arrangement, onion skin-like arrangement, the warts. Something like Samoa bodies, Samoa bodies, something classifications, necrotic classification here can cause the Samoa bodies. I'll show you some pictures, maybe better to show it in the picture. So this is what we call rosette formation, the arrangement of the cells around a lumen, rosette. Sometimes we say pseudo-rosette. Pseudo-rosette, there's no lumen, or the cells by themselves arranging around blood vessels. So arranging around blood vessels is called pseudo-rosette. Arranging around the hyalinized necrotic material, we call pseudo-rosette, and so on. We start with the glioma. We said that we start with the cell of the origin. The most common neoplastic process in the CNS tumor primary. We need to separate between primary and the secondary. Secondary means metastatic into the brain. The most common neoplastic process in the brain is the secondary, not the primary. 25 to 50% of CNS neoplasm are actually secondary. So here we are talking about the primary tumors. Primary tumors originating from the CNS itself. The most common one is the glioma. So glioma are the most common tumors in the CNS. With these gliomas, depend on the cell of the origin. We said we go to the cell of the origin. We have the astrocytoma, oligodendroglioma, ependymoma, and sometimes mixed cells. So it depends on the cell type. Now we go to the grading. Grading is very important. Grading, WHO grading, the criteria based on these components. What's grading? Sometimes we say grading, sometimes we say staging. What's the definition of grading?
Like how different the cells are compared to the normal cells?
Excellent. Grading is how close the cells, the neoplastic cells, to the benign normal component. So we said grade 1. Grade 1 what? What differentiated? What would differentiated mean?
You can tell where they go to the origin.
It looks like very close to the origin. When we say adenocarcinoma, well differentiated grade 1. That means the adenocarcinoma, the neoplastic, it looks like similar to the origin. We see glands, mitotic activity low, pleomorphism low, and so on. So this is grade 1. Sometimes we say grade 2. That means the features are less. The neoplastic component is similar to the origin. When we say poorly differentiated means the neoplastic process is away from the normal. Like in adenocarcinoma, we don't see glandular differentiation. We see a lot of mitotic activity. We see a lot of pleomorphism. So this is grading. Now we move to staging. There are two terms we use in the pathology: grading, staging in the neoplasia. What's staging? What we answer in staging, we said in grading that we see how close the neoplastic process into the normal. Well differentiated, moderately, poorly differentiated. Now staging. What's staging? Yes.
Is it about metastasis? How much of it is spread?
Metastasis. Staging about metastasis.
And the size? How severe the size of the tumor?
Size of the tumor.
How severe the cancer is?
How?
Severe the cancer.
How severe the cancer? How severe or how bad the cancer is grading, isn't it? How bad histologically is the grading?
How much is embedded into the surrounding tissues?
What else? Actually, partially, okay. You know, in staging, we answer a question. What the question we answer in staging?
How far does it have to go? How far it has to have to go?
How far the tumor is going on? Good answer.
Like membranes, facing membrane, or like in the blood, or on the tissues.
So, in other way, we answering one simple question.
Which stage of the spread?
How much it has spread?
Where is the tumor now? Where is the tumor now? The tumor is localized. Like in colonic adenocarcinoma, stage 1. Okay, the tumor is still in the mucosa, submucosa. And there's no lymph node metastasis. And there's no distant metastasis. You know, we use 3 parameters in staging, the T, N, M. Tumor, N for what? N for lymph node, and M for distant metastasis. So we say stage 1 tumor, N0, M0. The tumor is still in the mucosa, submucosa. Lymph nodes are negative, metastases are negative. This is stage. Stage 1, N0, M0. The tumor is still in the mucosa. Sometimes we say, okay, tumor is stage 2, N0, M0. The tumor means it's embedding into the muscularis, and so on. So staging answer the question, where is the tumor now? The tumor is still restricted, no lymph node, no distant metastasis. So which is more important, staging or grading? We use both, huh? So which one more important, you think?
Staging.
Staging. Both are equal.
Excellent. So the staging is much, much more important than grading, because staging is related remarkably to the prognosis of any disease. So in the brain, now we are going for grading. How we grade it? We grade it depends on cellularity, nuclear atypia, endothelial proliferation, and necrosis. So 4 histopathologic parameters: cellularity, nuclear atypia, necrosis, vascular proliferation. And there is another parameter we don't use outside the brain actually, mainly in the brain: molecular findings. Molecular genetic findings are very, very important in grading of neoplastic process in the brain, which means we have to combine all features together to get the right grade. You know, you see some features here like endothelial proliferation. Endothelial proliferation is a very important factor in grading of brain tumors. Did you ever hear about endothelial proliferation as a factor in grading outside of the brain?
Yes.
Where?
Like
For grading?
like
Not available anywhere else. We never use vascular proliferation to say this is a grade 2 colonic adenocarcinoma or grade 3 lung cancer and something like that. So specific features for the brain: cellularity, necrosis, microvascular proliferation, pleomorphism in the nuclei, in addition to the genetic molecular abnormality. What does that mean? Why we use genetic molecular abnormality in grading, not in prognosis, not in treatment? We use it in grading.
because it shows how different it is to compare to other cells, other benign cells.
Yeah, it shows you how it's different from others, from other tumors, from other grades. But in the brain, actually, we use it in grading, which is really very unique. Like, if I have a brain tumor, grade 2 brain tumor, it looks like grade 2, it's very well differentiated tumor, grade 2. We do the molecular studies, we find some molecular findings, we right away jump it into grade 4. This is not happening anywhere else. So molecular important in the grading of neoplastic process in the brain, in addition to the histopathology. Astrocytoma is the most common glial tumor. It's astrocytoma either localized or diffuse, Many times we see the astrocytoma in the cerebrum. It ranges from grade 1 to grade 4. So astrocytoma range from grade 1 to grade 4. Manifestation, it depends on the type of the tumor, location, size, and so on. So behavior different, clinical presentation different from patient to patient, depending on the tumor itself. Age is important, you know. Astrocytoma in the adult age is more common in the cerebral, in the anterior, while in the childhood is more common in the posterior. Why you are late, please? Why you are late? Why, both of you? Sorry?
We are very sorry.
Good answer. To say. Next time, there is no next time this year. For next year, nobody come late to my lectures. Be careful. I highly respect the female students, highly, but kindly don't come late to my lectures next year. This year there is no more lectures for you. Next year, okay? So clinical manifestation depend on the location of the tumor, how bad the tumor, size of the tumor, and so on. We say there glial tumor, the astrocytoma, are from grade 1 to grade 4. It's either localized or diffuse. The grade 1 astrocytoma is the localized one. This is the only localized tumor that it's grade 1 tumor. So localized, well restricted. We call pilocytic astrocytoma. It's grade 1 astrocytoma. We have grade 2 astrocytoma, grade 3 astrocytoma, grade 4 astrocytoma. Remember, grade 3 and grade 4. In grade 3 and grade 4, there is a lot of abnormality, cellular abnormality, but there are two features that classify any astrocytoma glial tumor into grade 4. One of them is necrosis, and the second is microvascular proliferation. So if we have any of these features, the tumor is right away grade 4. So abnormality, a lot of abnormality, grade 3. A lot of abnormality plus necrosis or microvascular proliferation mean grade 4. Any of these features mean grade 4. Glioblastoma, it's a very commonly used term, glioblastoma. Usually we use glioblastoma for high-grade glioma, for grade 4 glioma. Actually nowadays the terminology of glioblastoma are really restricted to sub-grade 4 astrocytomas where we don't have some genetic abnormality. So just remember, glioblastoma most likely is grade 4 astrocytoma. Okay? So grade 4 mean glioblastoma. Glioblastoma mean grade 4, but the difference between the two is the presence or absence of some genetic abnormality. Close your cell phone, you. Close your cell phones, both of you. Okay? So we go to the pilocytic astrocytoma. We said localized astrocytoma, grade 1 mean pilocytic astrocytoma. Pilocytic astrocytoma is the grade 1 astrocytoma. Remember the features where we look for the astrocytoma. Grade 2, grade 3, grade 4 diffuse, always we call it diffuse astrocytoma, or grade 2, grade 3, grade 4 astrocytoma. These are the genetic abnormality that can be seen in each grade of the astrocytoma. You know, in grade 1, the pilocytic astrocytoma, actually we don't see IDH. Nowadays, we have to do the IDH genetic abnormality for any neoplastic glial tumor. So this is a must, the IDH presence or absence in any glial tumor. Why? You see that why? Because in grade 1, we don't see the IDH1 abnormality. In grade 2 and above, all of them, we see the IDH1 or IDH2 abnormality. So we say grade 2, grade 3, grade 4 astrocytoma with IDH1 abnormality. So what if we have high-grade glioma, but the IDH negative? We call it glioblastoma in this type. So we call it glioblastoma when we have a high-grade, grade 4 astrocytoma with the IDH1, IDH2 negative. In this way, in this time, we call the glioblastoma. You see how important the genetic abnormality. It's really defined, actually, the final grade of the glial tumor or the astrocytoma. We move to the pilocytic astrocytoma. Now we need to go through some kind of practical, physical, some memory kind exam or some memory kind parameters to remember, to fix the important information in this lecture. Like in each single entity, we need to know many parameters. Number 1, age. 2, location. 3, molecular findings. 4, histopathology findings. So if we start with the pilocytic astrocytoma, we say pilocytic astrocytoma is a grade 1 neoplastic process. Which age we see the pilocytic astrocytoma? Young age. Location? Histopathology in astrocytoma pilocytic, we see regular histopathology, regular cellular component. We see some cystic spaces, and we see what we call 2 important factors. We see Rosenthal fibers, which are hyalinized. You know, these are Rosenthal fibers. It's elongated, hyalinized component or forms, and we see eosinophilic granular bodies. So eosinophilic granular bodies, Rosenthal fibers. All of these can be seen in the pilocytic astrocytoma. Pilocytic astrocytoma many times shows cystic kind formation, cystic change. You see here the cystic spaces, so cystic formation. So this is the way we see the pilocytic astrocytoma. Young age, cerebrum, it's a regular cellular component with not much atypia, some cystic-like formations. We see typical morphology of eosinophilic granular bodies and Rosenthal fibers. So this is all we need to know. All we need to know about pilocytic astrocytoma. Can somebody repeat what we see in astrocytoma? Pilocytic astrocytoma. Can you repeat it? Yes, please.
We see the
And just higher your voice so they can. Age,
8 children. And
location,
location cerebellum. And then you see normal eosinophilic bodies, but you see some cyst-like formations in the cerebellum. And
Rosenthal.
pattern.
Yeah. What about the molecular? We don't see IDH1 or IDH2. It's negative. Okay, so all of these features are typical for pilocytic astrocytoma. Now, we said anything other than localized should be diffuse. So diffuse, the second one, diffuse astrocytoma can be either grade 2, 3, 4. So now we have an important issue here. Do we have grade 1 diffuse astrocytoma? The answer is no. So there is no diffuse grade 1 astrocytoma. By definition, diffuse astrocytoma is grade 2. And by definition, in grade 2, 3, 4 astrocytoma, what should we find in molecular? We should find IDH1 or IDH2. We said grade 2, 3, 4. How we differentiate between 2, 3, 4 depend on cellularity, pleomorphism, atypia, presence or absence of necrosis, mitosis, microvascular proliferation. So if we have dysplastic anaplastic change in a glioma, in astrocytoma, with focal necrosis, what we call this? With necrosis, what we call it? Right away, it's 4. If we have the same tumor, anaplastic astrocytoma without necrosis, without microvascular proliferation, it is 3. Okay, so this is the difference. Remember, all glial tumors are GFAP positive. The GFAP positive it's a must positive in all glial tumor. If the glial tumor is not GFAP positive, it's not a glial tumor. So remember that, please. This is grade 2 astrocytoma. We say grade 2 astrocytoma. You know, sometimes the definition is not that clear. Here's the tumor, here's the tumor. And this is the histology of grade 2 astrocytoma. You see the histology, grade 2, it's very close to the what? To the normal brain. But we see extracellularity, we see more cells, so extracellularity, we see some pleomorphism, we see some hyperchromasia, but there is not much mitotic activity, not much atypia. So this is grade 2 astrocytoma. If we go to the higher grade astrocytoma, this is a very bad cancer, isn't it? Very bad tumor, a lot of pleomorphism. And what's in the center? What's this? What is this?
Mitosis.
Mitosis. So mitotic activity, pleomorphism, hyperchromasia, very bad. But if we see just this, what we call grade 3. Why it's grade 3? It looks so bad. It looks very bad cancer. Because there is no microvascular proliferation. What about this one? So this is grade 4 astrocytoma. What if this one, IDH1, IDH2 negative? Glioblastoma. By the way, years ago, we didn't differentiate between the two. If I don't have genetic studies, I would call this glioblastoma. I don't have the IDH1, IDH2. We call it right away high-grade glioma, glioblastoma. But if I have them, I need to differentiate between the two. So this one, anaplastic astrocytoma or grade 3 astrocytoma. You see the astrocytoma here in one area, in maybe the left side of the brain. And this one is a high-grade glioblastoma or grade 4 astrocytoma. This is important. This is important clinical case scenario. Very important clinical case scenario in the CNS neoplastic process. Sometimes we see an aggressive tumor, and it's extending from one side to the other side, like a butterfly. You see? It's like a butterfly, it's in both sides. This is characteristic, typical for glioblastoma or grade 4 astrocytoma. So this is an example of typical glioblastoma, the butterfly appearance. So butterfly appearance is typical for grade 4 or glioblastoma multiformis. You see, glioblastoma multiformis. We said the seeding into the CSF, it's extremely rare in CNS tumor. It can be seen in high-grade tumors like glioblastoma. So the CSF extension can be seen only in high-grade tumors, only in anaplastic tumors, CSF extension. How about the metastasis? The metastasis, I said, it's very rare to see metastasis outside the brain. So brain tumors usually stay in the brain. However, there are rare cases of high-grade glioblastoma or glioblastoma going into bone, going into lymph nodes, and so on. But these are really, really rare cases, not the regular. Glioblastoma survey is just a glial tumor that extending diffusely into the brain, into multiple parameters in the brain. This is an interesting tumor. Pleomorphic xanthoastrocytoma. It is an astrocytoma, but as I said, we need to go through the features, the parameter we normally use. So this is astrocytoma, type of astrocytoma. Age, it looks like in young adults. Location, temporal lobe. Anything unique about this tumor? Yes, it presents in many times with seizures. Pleomorphic xanthoastrocytoma. The histology of this tumor with the name, pleomorphic. It looks like a very bad tumor. So it looks like a very bad tumor. You know, if you show me this picture, and you don't tell me that this is from the brain, I tell you this is a very high-grade neoplastic process. It's a high-grade aggressive tumor. But in the brain, in this location, in this age, this is most likely pleomorphic xanthoastrocytoma. This tumor most of the time is a low-grade tumor, grade 2 tumor. With all of this abnormality, it's still low-grade tumor. Why? Because this is the definition of this tumor. We see in intranuclear inclusions, we see many intranuclear inclusion, we see a lot of bizarre cells, but there is something missing in this histology. Mitotic activity. We don't see mitosis, and we see a lot of reticulin in this tumor. So if I go back to characterize the pleomorphic xanthoastrocytoma, it's seen in young adult. Location, clinically present with seizures, a lot of abnormality, cellular abnormality, a lot of nuclear atypia, but there is no mitotic activity, and for that reason it is most of the time a low grade. Good?
Yes.
So you know now about pleomorphic xanthoastrocytoma more than anybody else. More than you need, actually. Perfect. Oligodendroglioma. Oligodendroglioma is a tumor coming from which cells? Oligodendrocyte. What the normal oligodendrocyte cells? Yeah, morphology, small cells, rounded, isn't it? Small rounded cells, regular cells, and there is what around the nuclei in many times? We see halo, clearness around the nuclei. So this is a typical oligodendrocyte. So if we have a tumor of oligodendroglioma, most of the time, most of the oligodendrogliomas in the cerebrum, many times it showed round, small, regular, round, small cells. This is the normal cells seen as an oligodendrocyte. So uniform cells. So we see this fried egg. The fried egg means there's halos around it. So these are good important features. The fried eggs, and we see something else. We see it in radiology too. What is this? calcification. So now we're good with the oligodendroglioma. It's a tumor seen most of the time in the adult life, in the cerebrum. Histologically, we see oligodendrocyte with the fried egg. We see calcification. IDH1, IDH2 most of the time are there because it's a glial tumor. And GFAP positive or negative?
Positive.
Always positive for GFAP. Grading, usually grade 2. Sometimes we can get anaplastic oligodendroglioma, but usually it's grade 2. So grade 3, we can have it with anaplastic features. So that's all you need to know about oligodendroglioma. Now ependymoma, third cell outlining the ependymal, are like the ventrix. The cells in the ependymal cells are cuboidal cells, so the tumor of ependymoma usually present or originate from the ependymal cells. Many times it can be in the cerebrum or in the brain itself, in the CNS, in the brain itself, or in the spinal cord. In the spinal cord, there are subtypes of the ependymoma. So the location different from the cerebrum to the spinal cord. Some genetic abnormalities, we can see the neurofibromatosis 2 and chromosome 2. P53 sometimes can be seen. Yeah. So the histology of the ependymoma, and many times in ependymoma we see the cells trying to do the same. So in the neoplastic process for ependymoma, the cells trying to do what looks like arranging around the blood vessels. This is what we call what? The cells arranging, palisading around blood vessels, pseudo-rosette. So this is very typical for ependymoma. Sometimes the cells making a real rosette or tubules. So this is the histology of the ependymoma. Most ependymomas actually are grade 2 tumors. Remember, for the immunostains, we use the GFAP, is 100, vimentin, and the epithelial membrane antigen. There are specific types of the ependymoma. One of them is this one. It's very important. We call myxopapillary ependymoma. So what features of myxopapillary ependymoma? The features of myxopapillary ependymoma, limited. Number one, the location in the terminal part of the spinal cord. So location is important for this type of ependymoma, myxopapillary. What other features? Myxopapillary. It's a myxo, so there's myxoid, and it's a papillary, so there's papillary formation. So features of myxopapillary ependymoma, location in the filum terminale, in the terminal part of the spinal cord. It shows myxoid, it shows papillary formation. More than enough. More than enough. What about anaplastic ependymoma? Anaplastic ependymoma is an ependymoma with anaplastic. The word anaplastic means what? We said anaplastic whatever. What mean? What does that mean? Like anaplastic lymphoma, anaplastic carcinoma, anaplastic astrocytoma, anaplastic ependymoma. What does that mean?
Are you differentiated?
Poorly differentiated.
Sorry.
Yeah, mean a tumor that is very aggressive. Very aggressive, which means it is a poorly differentiated. So, poorly differentiated ependymoma, it's grade 3 ependymoma, mean anaplastic ependymoma. So anaplastic mean poorly differentiated neoplastic process, regardless of the terminology. Anaplastic lymphoma mean the lymphoma cells are very bad looking. Anaplastic carcinoma mean the epithelial cells are very bad looking cells. Anaplastic sarcoma mean the cells or the neoplastic sarcomatous cells are very bad looking. Anaplastic ependymoma means high-grade ependymoma. You don't need this. Very complicated. Prognosis for ependymoma depends on the stage, depends on the location, how could easy take the tumor out, and so on. I don't know why you stopping us this time. You have a problem here with this computer. You should tell them the. You should tell them to. Yeah. Now we go to a specific type of tumor. We call it embryonal primitive tumors. Small round cell tumors. You know, in neoplasia, we use some terms regularly. Like we use small blue cell tumor. Sometimes we use small round cell tumor. What does that mean? Anybody knows what small round, small cell tumor? Small and round. Actually, small and round cell tumors, same as synonym for small blue cell tumors, mean that we have a tumor that is very aggressive, but the cells are very small in size, and blue, that means hyperchromatic. When we say round, mean the cells are small and round. Remember, all of these small round cell tumors usually are very bad tumors. Most of these small round cell tumors are primitive tumors. Most of them seen in which age? In young age, in the childhood, in the pediatric age. So small round cell tumors, small blue cell tumors seen in younger age. Some of these small blue cell tumors can be seen in old age. Anybody knows what differentiate when we say small blue cell tumor, small round cell tumor? That means we mean some group of tumors, isn't it? That we mean some differential diagnosis. Anybody knows what small round cells and smarts well knows what small round, small blue cell differential diagnosis? One of them is the medulloblastoma. What else? Excellent. Ewing sarcoma. What else? Small malignant, small round cell tumor. So she said Ewing sarcoma. What else?
I think that's the only one we talked about. Ewing sarcoma, I think is the only one we talked about.
Sorry?
I think Ewing sarcoma is the only one we talked about.
Ewing sarcoma. Yeah, what? What you said?
Small cell lung carcinoma.
Excellent. Small cell carcinoma. But small cell carcinoma seen in which age? We said most of these small round cell tumors seen in young age. But this one, small cell carcinoma, seen in old age. What else? Now we are three. Sorry? Osteosarcoma most of the time is not small actually. Osteosarcoma pleomorphic. There is some type rare from osteosarcoma small. Sorry? Rhabdomyosarcoma. Very good. I need two more and we stop.
Osteoid.
Come on, osteoid is a benign tumor. I said all of these tumors are high malignant tumors. Two more. What is it? Burkitt. You could say lymphoma. Excellent. One more. Neuroblastoma. Good. So all of these are examples of small malignant round cell tumors. All of them, you see all of them are seen in childhood except the small cell carcinoma. So now we have primitive tumor. You forget the brother for the medulloblastoma, which is the neuroblastoma. The neuroblastoma that can be seen anywhere in the CNS. So medulloblastoma is a very bad tumor, seen in childhood, seen in the cerebrum. The cells are very small, very aggressive. It causes some rosette in histology. These are the rosette in histology. So in overall, it's a very bad tumor seen in the childhood, the medulloblastoma. Remember, any neuroendocrine, any neuroepithelial tumor should be synaptophysin positive. What's the other marker for neuroepithelial tumor we use? We use the synaptophysin and what? What do we use for the neuroepithelial in addition to the synapto? Actually, we always say them together. Synaptophysin and GFAB for layered tumors and chromogranin. So synaptophysin and chromogranin for any neuroepithelial tumor. So now we need to define. It's important to memorize this. For medulloblastoma, we have 4 groups on the molecular definition, and we have 4 groups by histopathology definition. It's important. In the molecular, we have 1 group, we call the WNT group. The other one we call the SHH group, and group 3, group 4. So 4 groups. SHH, WNT, group 3, group 4. I don't want to go in details for group 3, group 4. You don't need that. So 4 group and molecular basis. Now pathologically, we have also 4 groups. Why it's important to go to say that, yeah, there is the classical type. There is the desmoplastic. There is the one with extensive nodularity, and there is the large cell type. Why we go to all of these? Why don't just say medulloblastoma? We go into these subdivisions, some groups, because the prognosis is different. And the desmoplastic, the prognosis is better. And in the large cell, the prognosis is very poor. So that's why it's important. So we have classical, desmoplastic, nodularity, extranodularity, and the large cell type. 4 group of the medulloblastoma. Another tumor, atypical rhabdoid teratoid tumor. Atypical teratoid rhabdoid tumor is a very unique, specific tumor. We go to whenever we have unique, different tumor, then better to go to the parameters we used. So we pick it up easily. You know, many times the name, the terminology gives you features of that tumor. We start with the age. Atypical rhabdoid teratoid tumor usually start very young age group, less than 3 years. Most of the cases less than 5 years. So age is very young, pediatric age, less than 3 years. Location in actually any tumor in pediatric age, just keep this in mind, most of the time in the posterior. Yes. Now, histology, histopathology or histology, how can we pick up the histopathology in this weird tumor? It's really weird tumor. We say atypical rhabdoid teratoid. Actually, if you just go to the name, atypical rhabdoid means it shows some rhabdomyoblast differentiation. Mean we have mesenchymal. Teratoid, what teratoid? What teratoma? What we see in teratoma?
Mixture of cells.
Mixed germ cell component in teratoma. So teratoid, that means we can see epithelial, we can see neuro, we can see mesenchymal in this tumor. And that's it. So it's atypical rhabdoid teratoid tumor. It has multiple components, which are epithelial, mesenchymal, neuronal, and so on in this tumor. Molecular, always the I in I is missing, is lost in this tumor. So now we have complete picture about this tumor. Age, location, histopathology, and molecular. And we more than done with this tumor. Okay? So molecular is the iron I lost. Histology, we said the histology molecular component. Location, we know it's in the posterior. And age is very young age. So this is atypical Raddaoui tumor.
Can you have just a minute's break? Yes, Doctor, please, so we can focus on the old one.
Yeah.
So you have two choices,
Okay, yes.
two differentiates.
Okay.
Number one, to take a break, 5-minute break, 5 minutes, maybe less than 5 minutes. And number two is to go fast and finish. We are almost there.
Let's just finish it.
Yeah, let's just finish.
It's up to you.
No, let's finish.
Finish?
Yes.
You change your mind. So let's, okay, are you satisfied?
That's this one, no?
Okay. So, lymphoma, can we see lymphoma in the CNS? Just remember, lymphoma, mesenchymal tumors, these cells are present everywhere. So the tumors can be seen everywhere. We can see lymphoma in the CNS, we can see lymphoma in the GI tract, we can see lymphoma in the skin. So lymphoma can be seen in the CNS tumor. It can be present as a CNS tumor. The most common lymphoma is diffuse large B-cell lymphoma. Lymphoma seen in brain many times in specific type, in specific group of patient. Which group of patient shows in many times lymphoma? The excellent, the immunocompromised HIV patient. The immunocompromised patient can show many lymphomas in the CNS. So this is about lymphoma. Germ cell tumors can be seen anywhere in the midline. In the CNS, we can see germ cell tumors in the midline, close to the pineal gland. Just remember, germ cell tumors in the brain, it's rare tumors. Germinoma, it's kind of the seminoma and teratoma, whatever. In germ cell tumors in the brain, we need to remember something. You know, we can see germ cell tumors outside the brain. And these tumors, in many times, metastasize to the brain. So we need to differentiate if these germ cell tumors are primary or secondary. Where can we see with the origin of metastatic germ cell tumors? Most of the time, the origin of the metastatic germ cell tumors. Testicle in male and ovaries in females. So we always check in males the testicle and in females the ovary for primary germ cell tumors. Meningioma are tumors of the meningeal cell origin. You know the meninges outlining the brain. So any tumor originating from the meninges, we call it meningioma. Meningioma is actually is the most common tumor. There are some abnormality like loss of the chromosome 22. Prognosis of meningioma depends on the grade of the meningioma. Grading is the most important factor in meningioma. Now we have meningioma grade 1, grade 2, grade 3. Meningioma grade 3, it looks like sarcomatous meningioma. A grade 1 meningioma is a very well differentiated meningioma. So the problem in which one? In grade 2. Now we need to jump from grade 1 to grade 2. It's so important for the management. So grade 2 meningioma, we need to have either 4 mitotic activity in 10 high-power field, or we need to have 3 abnormal histologic findings out of 5. What are these abnormalities? Number one, cellularity, small cell type, with high NC ratio, macronucleoli, and patternless pattern, that means the proliferation is irregular, patternless pattern, or necrosis. So we have more than 3. Any 3 of these is enough to call grade 2 meningioma. Another parameters, remember there are some meningiomas shows clear cell type. Some meningiomas show chordoid cell type. Any meningioma, chordoid or clear cell, defined as grade 2. So now we're done with it. So with the grade 1, the grade 1 is the benign one, which has none of these features that we mentioned. I mean, less than 3 histopathologic, cytologic features, or less than 4 mitotic activity. So grade 1, grade 2, grade 3 meningioma is a very aggressive tumor. Grade 3 meningioma is kind of sarcomatous tumor. So grade 3 meningioma is a very aggressive. It looks like a carcinoma. It looks like a sarcoma. And there are some subtypes of meningioma that we always grade them as, or put them in grade 3. These are the papillary and the rhabdoid. So papillary rhabdoid meningioma always grade 3. Chordoid clear cell 2. Meningioma with more than 3 cellular abnormality 2. Meningioma with more than 4 mitotic activity 2. Otherwise 1. Meningioma behavior many times is slow growing benign tumor most of the time. One more thing, the TERT promoter or the TERT promote mutation right away, and the CDK in 2A or B jump the meningioma into grade 3. So sometimes we have a grade 2 meningioma, and if we get any of these molecular abnormality, we push it to grade. This is the meningioma. See the meningioma. This is the subtypes. These transitional, fibroblastic, syncytial, some homobodies, all of these subtypes of meningioma. The meningeal cell proliferation will take one of these forms all the time. Some momentous, fibroblastic means spindle cell. Syncytial means there's no clear cell borders. Metastatic, remember I said, actually there's a very common question. The most common malignant neoplastic process in the brain, number 1 is metastatic tumor. So metastatic tumor is the most common malignancy seen in the brain. Which tumors go into the brain? Which the most common malignancy in females go to the brain? Breast and others, renal and others. In the male, lung. So lung, male, breast, female. I think that